is Dr. Jerome Lyn-Sue. I'm from the Division of Minimally Invasive and Bariatric Surgery. This talk is going to be about dysphagia, difficulty swallowing, and I'll try to concentrate on more of the benign causes of dysphagia. So let's get going. So let's start with some basic definitions. Dysphagia is basic difficulty swallowing. The other term that you might come across is odynophagia, which is painful swallowing. And patients will come presenting with these symptoms from time to time. Probably not both, but usually at least once. I'll start off with some anatomy and histology, getting into some testing and then some clinical scenario situations. So the esophagus is a hollow muscular tube. It extends from the C6 level of the cervical vertebrae. It starts at the cricopharyngeus muscle. It extends in the posterior mediastinum in the chest down to your T8, T10 diaphragmatic hiatus opening. Then it enters the abdominal cavity. There are some anatomic narrowings. So at the upper esophageal sphincter, the beginning of the esophagus, this is denoted by the cricopharyngeus muscle. So that is our first narrowing. Where the arch of the aorta crosses the bronchus, that's another area of physiologic or normal narrowing. And when it exits the thoracic cavity and goes into the abdominal cavity at the T8, T10 level, that's another area of narrowing. So when doing an upper endoscopy, it would be it's always advisable to do it under direct vision. So if somebody has strictures, esophagitis, and you have these areas of narrowing, you can actually cause you're going to prevent an iatrogenic perforation. As far as musculature goes, the upper third of the esophagus is striated voluntary muscle, while the middle third is a mixture of both striated and smooth muscle, and the lower third is smooth involuntary muscle for progression of peristalsis. Going down to histology, the layers of the esophagus is similar to any hollow viscus. It has a mucosa, submucosa with muscular layers. So if you look on the diagram on the upper right, we have our epithelium. So in the esophagus is squamous epithelium, your typical basement membrane, lamina propria, and then you get your submucosa with your musculature. So we have an inner circular and an outer longitudinal muscle layer. The difference with the esophagus versus the small bowel or large bowel is that there's no serosa. So all you have is this periesophageal tissue or adventitia type tissue. Therefore there's one less layer. So this tells us that when we're doing esophageal anastomosis, although the serosa doesn't give much strength, but it's one less layer, so the risk of an anastomotic leak might be a little bit higher than with small and large bowel. And the position of the esophagus, it's in the mediastinum. So if you leak into the mediastinum, that can lead to mediastinitis and very significant morbidity and subsequent mortality. And as we said before, as far as epithelium goes, it's squamous epithelium lining the esophagus. There is a Z-line or a junction between the esophagus and the stomach where the squamous epithelium changes to your columnar epithelium with goblet cells. So this is just normal transition zone, and this kind of coincides with your lower esophageal sphincter, your diaphragmatic hiatus, and usually occurs around 40 centimeters from the upper incisor when you're doing an endoscopy. All right, let's get into blood supply. So if you think of it this way, the blood supply of any organ, no matter which cavity traverses, say the esophagus is in the neck, then it travels in the thorax, then in the abdomen, it will get blood supply from any nearby vessels. So in the neck, the cervical esophagus will get branches from your inferior thyroid artery, your thyrocervical trunk. As you get into the thoracic cavity, you'll get branches from the intercostal arteries, direct branches from the aorta itself, and down in the abdomen, the upper esophagus, the lower esophagus, and the upper stomach is supplied by the left gastric artery, which we all know comes from the celiac axis, along with the splenic artery and the common hepatic artery. Similar goes for the venous drainage. So we can see the cervical esophagus drains into the internal jugular vein, inferior thyroid vein. As we get into the thoracic cavity, you will see azygous veins on the right and hemiazygous, accessory hemiazygous on the left. In the abdominal cavity, similar drainage to the IVC through your short gastric veins and so on. Let's talk about the sphincter mechanism. So the esophagus has an upper esophageal sphincter and a lower esophageal sphincter, and the main reason for these is to prevent air and into the esophagus and reflux into the esophagus from the stomach. It kind of keeps the lower esophagus closed, so you can belch at a more socially acceptable, or not belch when it's socially unacceptable. So these are the things that could help that. So the upper esophageal sphincter, it, as we said before, is at the level of the C6 cervical vertebra. It measures about 4 to 5 centimeters in length. It does have a resting basal pressure when you look at manometric findings. So it's about 60 millimeters mercury, and it corresponds to a muscle. So this is the cricopharyngeus muscle as the pharynx transitions to the upper esophagus. As far as contractions go, as with any hollow viscous, there is contraction, peristalsis, which causes progression of the food bolus and the intestinal content. So there's primary contraction that's after swallowing, that's more of a voluntary, involuntary type maneuver. When you get to secondary contractions, it causes propulsion of the food bolus distally, and that means if the distal esophagus becomes distended, it causes contraction of the proximal esophagus and relaxation distally to allow progression of peristalsis. And then tertiary contractions are like non-progressive, non-peristaltic, almost like a spasm. This can occur from time to time, and if it occurs too often, it can become pathologic. The lower esophageal sphincter, which is probably one of the more common regions that we worry about, or how patients present, it is a physiologic sphincter. There is no muscle like the upper esophageal sphincter that defines this area. It acts as a barrier to reflux. It's considered a high pressure zone. It does have some length to it, so if you do manometric measurements, you'll have a 3 to 5 centimeter area of high pressure, which is about 24-25 millimeters of mercury at that Z-line GE junction, 40 centimeter distal to the incisor. It does have some intra-abdominal length, so the whole mechanism of the esophagus being partially in the stomach, that angle of His that we speak about, as well as the high pressure, somehow causes contraction of this high pressure zone to prevent recurrent reflux. So if say the stomach is distended, the distension of the stomach will cause lifting up of the fundus of the stomach, more acute angle of His, which kind of cuts off the lower esophagus and prevents food from going proximally, and hopefully the gastric contractions will push the food bolus or digested food distally towards the pylorus. So this high pressure zone varies. It's basically a parasympathetic stimulation that causes relaxation. In pregnant patients, the hormonal changes will cause decreased pressure in this lower esophageal sphincter region, causing more reflux. Nicotine, caffeine, red wine, etc. will exacerbate reflux. So these are some of the triggers that patients might present with. So as far as symptoms, for benign disease of the esophagus, the two main problems you will be encountered with is patients who have reflux disease. That means the lower esophageal sphincter is probably too loose, and achalasia, where the lower esophageal sphincter is considered to be too tight, and is paramount to try to differentiate these symptoms. But if you look at the symptomatology, patients with reflux disease will have your typical, heartburn, chest pain, spitting up, regurgitation. But if you think about it, patients with achalasia will have very similar symptoms. They'll have regurgitation, spitting up. So the history itself doesn't tell you too much to differentiate one disease process versus the other. Couple key things here. If someone has a lump in the throat, it tells you that their pathology is more in the upper esophagus than in the lower. So chest pain, we said, chest pain, heartburn, most patients will say, most reflux patients will have this, but achalasia patients can have this as well. Hoarseness, cough kind of tells you more upper esophageal disease. If you hear bad breath, if you have bad breath in your, say, exams or shelf testing, then this kind of tells you it's more of a upper esophageal, maybe a Zenker's diverticulum type issue. Patients who have achalasia will present with weight loss, and in kids who have reflux disease, they won't say, I'm having chest pain, or what they'll have is failure to thrive, and they'll have recurrent pneumonias or recurrent admissions to hospital for airway disease, and they have the reason for this is silent aspiration. So workup is key. So as far as workup goes, we need to figure out what the anatomy of the esophagus looks like, and what the function of the esophagus is, and the sphincter mechanism as well. So we'll incorporate imaging, pH monitoring, manometry, and endoscopy. We'll do, as far as, say a reflux patient, they'll probably come in with 2 or 3 of these workup modalities before we actually make a diagnosis and start treatment. So as far as radiology goes, we'll kind of go through a few clinical things that you might see in this and try to relate it to some pathology. So let's start on the left. So this is a proximal dilation of the esophagus with a distal tapering called a bird beak sign or rat tail sign. This is consistent with achalasia. So on the right, we can describe this as a smooth filling defect in the mid-esophagus. This could be due to external compression. You could say could be a benign process. One of the more common benign problems of the esophagus is leiomyoma or a lipoma of the esophagus. These are usually asymptomatic and are found incidentally on workup. Continuing with radiology, you could describe this barium swallow study as upper esophageal in nature. There is shouldering or apple core type deformity. It's certainly not smooth. This is consistent with some kind of malignancy or malignant stricture. So this is how we kind of look at our radiographs and see pathology. If you look at these two pictures, this is a barium swallow of the upper esophageal region. This is an outpouching, usually on the left side of the neck, with an air fluid level, and this is consistent with your Zenker's diverticulum, which we'll go into shortly. Typical chest X-ray can be helpful. So here we have a gastric bubble in the chest. So this tells us that the fundus of the stomach at least, is in the thoracic cavity. So this is consistent with someone with a hiatal hernia, paraesophageal hernia. All right. Endoscopy. So most patients will need to undergo an endoscopy to look for changes, but these patients are presenting with dysphagia, so you certainly want to rule out any malignant cause or suspicious cause of this malignancy, of this symptom, of this symptomatology. So here, this is upper endoscopy, looking at the lower esophagus. This is Barrett's esophagus. Here, we've injected acetic acid, so similar to say, colposcopy in GYN looking for cervical cancer, cervical neoplasia, cervical metaplasia. So here the metaplastic cells will show a little bit different than normal mucosa, and if you biopsy certain areas, you'll have a higher yield when you're looking for Barrett's esophagus, which is essentially metaplasia from your typical squamous epithelium to columnar epithelium in the lower esophagus. Here we can see maybe a fungating necrotic type lesion intraluminal, so biopsies may show malignancy. This in the right lower corner of the slide, this is a retroflex view of our endoscope. So we're in the stomach now, looking upwards into the back onto the scope. So the scope is coming out through the lower esophagus and now into the stomach. You can see an opening here. This is your GE junction, your lower esophageal sphincter, and when you look up here, there's another constriction or narrowing here, and this is probably the diaphragmatic hiatus, the crura of the diaphragm squeezing the stomach. So this part of the stomach is deep and in the thoracic cavity, while this part of the stomach is in the abdominal cavity. So this would represent a small or medium-sized sliding hiatal hernia. All right. This endoscopic finding, you have smooth-walled longitudinal channels here. So this is consistent with varices. So these are things that might show up on endoscopy. On the right, this is another retroflex view. So this, certainly could be your GE junction, lower esophageal sphincter, esophagus exiting through the esophagus. Endoscope exiting through the esophagus. This is your gastric fundus. Seems to be deep, so this could be in the thoracic cavity, or could this be the fundus under the left hemidiaphragm? So this could be as severe as a large paraesophageal hernia, or as simple as a normal endoscopic view. So one study doesn't lead to your diagnosis. So you need to maybe have a barium swallow, manometry, and so on to actually come to a reasonable conclusion. All right, so 24-hour pH probe. So these are for patients with where you suspect reflux disease. So it's placed endoscopically. So these are pH probes that go down to the esophagus. They have pH sensors at different levels, and what it does, it's a 24-hour monitoring device, and it records any change in pH as the reflux abdominal gastric contents bathe the sensors, and over time the patients will record when they have symptoms. So for example, if say a young patient has pain at 10 o'clock at night, 12 o'clock at night, they can record it, and if you check your readings, if there is acid coming up at 10 o'clock and 12 o'clock, that means their discomfort is attributable to the actual reflux. If they have no reflux but have pain, then their discomfort is not due to reflux disease. So this helps in creating a treatment plan for this patient. So manometry is one of our studies that we use to assess the esophagus and function of the esophagus. As we know, normally there is an upper esophageal sphincter with a resting pressure about 50 to 60 millimeters of mercury in the cricosophageal region up here. Patients will swallow, then you'll have relaxation of the upper esophageal sphincter. You'll have progressive peristalsis as the wet bolus or the food bolus goes distally through the esophagus. When it gets to the lower esophageal sphincter, what you should see is complete relaxation of the lower esophageal sphincter and passage of the bolus distally. So this is a normal manometric tracing. Oops. All right, so this is a, we call it a high def or a 3D type representation of our manometric swallows. So here is the upper esophageal sphincter denoted by high pressure in orange, and there's progressive peristalsis. And here at the lower esophageal sphincter there is complete relaxation, so the orange turns to green or green-blue, and then it's a normal swallowing mechanism. So if this remains orange all the time, there's incomplete relaxation, it will clue you into more of a lower esophageal sphincter high pressure zone or achalasia type symptoms. If patients have orange all the way down and minimal progression of peristalsis, they'll have esophageal spasms, which can cause pain. So this kind of helps make a cone down on your diagnosis. All right, so let's go to our clinical scenarios. So as far as motility disorders go, we'll be talking about achalasia, some upper esophageal dysfunction, and some spasm, and then we'll talk about reflux as well. So as far as upper esophageal dysfunction goes, this is not very common. Patients will have their upper esophageal dysphagia type symptoms, where most of the symptoms are concentrated in the neck. They'll have hoarseness, weight loss, and reflux. So the symptoms can be all over the place, but the lump in the throat kind of clues you into more of a proximal esophageal problem. As we said before, we could use a combination of our diagnostic testing. So manometry will show a high pressure, barium swallow will show a holdup of the contrast at the upper esophageal sphincter, and endoscopy will try to rule out any malignancy causing this stricture. Right. Treatment is dilations if the patient has a significant narrowing. This will help the swallowing mechanism later on. Last resort, an esophagomyotomy, which is actually splitting the muscle, as well as a cricopharyngeus muscle to allow increased patency of that esophagus. All right, achalasia. So you'll probably be encounter this problem as well as reflux more often when it comes to benign diseases of the esophagus. So the hallmark of achalasia is failure of relaxation of the lower esophageal sphincter, as well as an increased resting pressure. It is, not uncommon, and patients will have the classic triad of dysphagia, regurgitation, and weight loss. And the younger kids or so on, they might have present with recurrent respiratory symptoms as the main problem. So as we said, there's impaired relaxation of the lower esophageal sphincter, and the etiology is due to a loss of ganglion cells of Auerbach's plexus between the muscle layers. You'll get asked about Chagas disease every once in a while. So this here, patients, it's usually found in South America. The vector is Trypanosoma cruzi, or the disease-causing organism is T. cruzi. Patients will present with loss of these ganglions and esophageal disease consistent with achalasia. They'll present with colonic or rectal disease consistent with megacolon or Hirschsprung's type symptoms. And these patients also present with a cardiomyopathy. So interesting disease process you can get asked from time to time. And as we said, as far as workup goes, the barium swallow will show you that proximal dilation, bird beak sign. The manometry will show you a high resting pressure greater than the 25 millimeters mercury, maybe up to 35-40. Patients will have incomplete relaxation, which is a hallmark of this disease, and they'll have absent or poor peristalsis due to the chronic obstruction. Certainly want to do esophagoscopy, endoscopy, and biopsy to rule out any malignant processes. Treatment for achalasia, it's basically interventional, but there are some medical options available. So for older patients or patients who are not fit for interventions, you can use smooth muscle relaxers like your calcium channel blockers, your nitrates. Botox has been used to make a diagnosis. So if patient has dysphagia type symptoms, high resting pressure, if you paralyze that lower esophageal sphincter, they'll have improvement of symptoms. And if that occurs, we know it's self-limiting, then we can move on to more definitive procedure. If you are sure of the diagnosis from your workup and symptoms, pneumatic dilation, which is rapid inflation of the gastroesophageal junction and rupture of the muscle fibers, have a good success rate, but the risk is perforation. Surgical Heller myotomy, which is dividing the inner circular and outer longitudinal muscles of the esophagus while leaving the mucosa intact, is considered the gold standard. There is a new procedure, a newer procedure coming, being popularized, which is a POEM procedure, which is per oral endoscopic myotomy. So this myotomy is done via an endoscope without any surgical incisions. They create a surgical a mucosal tunnel, submucosal tunnel. Endoscope goes outside of the mucosa and divides this muscle layer, and then proximally where we made the defect in the esophageal mucosa, we can clip it to prevent any leaks. So that is the new kid on the block, and is I think that's going to make the Heller myotomies go away. So this diffuse esophageal spasm, this condition is not very common, but patients will present with severe chest pain, retrosternal chest pain, some regurgitation, and it's usually triggered by stress. Workup will show high amplitude contractions, and your manometry will show 100, very high pressures throughout the esophagus. There's non-progressive peristalsis. When you do your barium swallow, you'll see just a spasm-like pan-esophageal contraction without progression. And the treatment for these things is basically try to avoid the triggers. Maybe you can use some calcium channel blockers or smooth muscle relaxers to help symptoms. All right, so let's go to a different group of disease processes. This is diverticular. So in the esophagus, it's not immune to have diverticular. In the proximal esophagus, you'll see your Zenker's diverticulum. The parabronchial diverticular will show up in the mid-esophagus, and epiphrenic usually occurs above the diaphragm. So as far as classification of diverticula go, as we know, a true diverticulum, like a Meckel's diverticulum, involves all layers of the viscus. First, a false diverticulum, like a typical colonic diverticulum, is due to increased pressure distally, so the pressure has to be dissipated somehow, so the mucosa kind of outpouches between the muscle layers. So these are your false diverticulum. So the Zenker's diverticulum occurs because there is cricopharyngeal narrowing or high pressure. So this is a false diverticulum. Epiphrenic occurs with maybe achalasia, so you'll have a false diverticulum being formed. And the parabronchial is usually a full thickness true diverticulum. So let's go with Zenker's. So Zenker's patients are usually older, over 60. There is a potential weak spot called Killian's dehiscence, which in this slide will show you there's a triangle between the pharynx and the upper esophagus. So this is the lower fibers of the inferior constrictor, upper fibers of the cricopharyngeus muscle, and the median raphe. So if the cricopharyngeus muscle is too tight, too hypertrophied, then there will be outpouching of this mucosa, and this is Zenker's diverticular. All right, patients will have the sticking in the throat, cough. They will have the halitosis. So whenever you see halitosis, it's they're trying to lead you towards Zenker's diverticulum. All right, the treatment. This is a benign process. So the key to treatment is a esophagomyotomy. That means we have to split the cricopharyngeus muscle. You can resect the diverticulum, or you can actually do a diverticulopexy, which is basically suspending the diverticulum upwards, so there's dependent drainage. There have been studies of endoscopic stapling, where without any neck incision you could do an upper endoscopy. This is an overtube. This is the esophagus with this arrow and the diverticulum lower down. You can actually divide the bridge with a stapler to allow dependent drainage. So bear in mind that this is not a malignant process. This is benign. So just drainage or free drainage is all that you need to achieve. All right, the mid-esophageal diverticular. This was more common back in the day when tuberculosis was very common. Patients would get this caseating necrosis of the lymph nodes or mediastinal lymph nodes that will cause scarring on the esophagus and pull on the esophagus, causing these true diverticula. They occur more commonly on the right side because we know the mid portion of the esophagus is in the usually in the right chest, because the esophagus goes from left neck, right chest, and left chest as it enters the abdominal cavity. So it makes a slight right-sided curve. Treatment: if they're symptomatic, you can resect, you can do a myotomy, but most of these patients they're found incidental and they're asymptomatic, so no need for any therapy. All right, epiphrenic diverticula. They occur after achalasia or some spasm type obstruction distally. Then there's this outpouching. Patients are usually asymptomatic, and if they're symptomatic, resection with a myotomy is the treatment of choice. As far as esophageal webs go, this is basically a medical disease, but it is quite interesting. It's the Plummer-Vince syndrome, where patients will have a thin film of epithelium in the esophagus, and just by doing an endoscopy you can break this film. So as far as dysphagia goes, just the diagnostic maneuver of doing an endoscopy will help their symptoms. As far as extraesophageal presentation, patients will have iron deficiency anemia, they'll have glossitis, spoon-shaped nails, described as koilonychia. As far as surgery, we talk about it because patients have an increased risk of squamous cell cancer. All right, we can go through this one quickly. So benign esophageal tumors. Leiomyomas is the most common benign tumor you'll see in the esophagus. It's usually in the younger age group, and patients are usually found incidentally. So if it's smooth walled, there's no need for therapy, no need for biopsy. If you do biopsy, you're probably going to find normal mucosa because it seems it's a submucosal lesion. All right, so the next big topic is your reflux. So if you think of reflux disease, Barrett's esophagus, and hiatal hernias, these are probably very similar disease process, but maybe different ends of the spectrum. So reflux disease tells you that patients will have heartburn, retrosternal chest pain, cough due to acid from the stomach going into the esophagus. Clinically, most patients will tell you when they have the symptoms, how often. If you examine the dentition, they'll have poor dentition due to the increased acid. If it's very severe, patients are usually sitting upright and leaning forward in the office, because that's how they use the diaphragmatic crura, how they use the diaphragmatic crura to close the lower esophagus to assist to prevent reflux from occurring. Your testing, as we described before, endoscopy, barium swallow manometry, and pH studies might help you make this diagnosis. So as far as hiatal hernias go, there's a classification scheme. A type 1 or a grade A hiatal hernia is a sliding hernia, where the GE junction slides up and into the chest and then back down, while the type 2 paraesophageal hernia is described as a rolling hernia, where the fundus of the stomach slides along the esophagus, but the GE junction is in the normal anatomic position and doesn't slide. The most common variation we see is a type 3 or grade C paraesophageal hernia, where the GE junction moves up and down, as well as the fundus of the stomach. There is a type 4 where you'll have the similar type 3 changes, but you'll have another viscous, another solid organ, or another organ in the hernia sac, and that could be spleen, pancreas, colon, omentum, and that's considered a type 4 hiatal hernia. So as far as Barrett's esophagus goes, we know it's due to an incompetent lower esophageal sphincter. Patients can have an associated hiatal hernia. There's certainly increased incidence in older patients and obese patients. And we know there are triggers like caffeine, alcohol, stress that can exacerbate these symptoms. It's more common in Caucasian than African Americans, and more males than females. Barrett's esophagus is basically columnar metaplasia from your squamous epithelium, and is considered a premalignant condition because it increases the risk of adenocarcinoma by 40-fold. All right, we spoke about this before. So for Barrett's, we can do an endoscopy, biopsy. Treatment varies from lifelong PPIs, proton pump inhibitors, to fundoplication. Patients, if you watch patients over time, survey patients over time, you may get high-grade dysplasia with progression to malignancy. So resection is part of your treatment algorithm. This is a diagram of a Nissen's fundoplication. So here we can see there's intra-abdominal esophagus being freed. Maybe there's a hiatal hernia that was reduced. The cruroplasty is performed. The right diaphragmatic crus is approximated to the left. Nowadays we use mesh as well. And then we have the stomach, the fundamentals of the stomach freed and encircling the lower esophagus. This is the vagus nerve. So increased intragastric pressure will cause distension of the Nissen's wrap, and that will actually cause increased pressure of the lower esophageal sphincter, hopefully prevent reflux. This treatment algorithm or management algorithm for Barrett's esophagus can be helpful. So in patients with no dysplasia or low-grade dysplasia, all you need is surveillance, whether it's every year or every other year. When you get to like high-grade dysplasia or early adenocarcinoma, you want to be pretty aggressive. So the algorithm kind of leads it towards esophagectomy. Major topic is esophageal perforation. So perforation of esophagus is usually iatrogenic. So after upper endoscopy, say someone has esophagitis or a stricture, if you pass your scope a little on the forceful side, you can actually cause a perforation. So most of these patients, if there is the management for these patients kind of vary from those patients who have spontaneous perforation where there's gross contamination. So we'll talk about a few of these. So when patients have perforation, as far as the spontaneous ones, this is usually after, say, having a heavy meal, maybe some alcohol on board. Patients will have strenuous vomiting, and that'll cause your malleolized tear, which is partial thickness, and subsequently, which can progress to a full perforation depending on the severity of the vomiting episodes. When patients have perforation, they'll have a history of vomiting, maybe some blood coming up. They'll have us display a septic picture. They'll be tachypneic, tachycardic, and if you examine the chest wall, they'll have this sub-Q emphysema, or the Hammond's crunch as we describe clinically. When doing your imaging studies, you can actually see pneumomediastinum, sub-Q emphysema on imaging studies, and if you do a gastrograph and swallow, you can see the area of perforation and extravasation of your contrast. So if it's lower esophagus, you'll see it on the left side. If it's mid-esophagus, it's going to be on the right side. It could be intrathoracic versus intra-abdominal, depending on the site. Treatment. So these patients are critically ill or going to be critically ill. So time is the most important, one of the key determinants of outcome. So if these patients are caught early, managed early, their outcome is better. These patients are invariably going to need ICU therapy, ICU treatment. If it's one of those endoscopic iatrogenic perforations where somehow the endoscopist felt a give and they're out of the esophagus into some false passage and then back into the stomach, then this would be a well-contained leak with no signs of sepsis. So NPO, antibiotics, maybe clipping or so on, that's maybe all that you need. When you get to contamination, if it's within 6 to 8 hours and patients are not unstable, you can try to repair with, not primarily, but with say a muscle flap or pedicle flap or something to try to reinforce the repair. If it's gross contamination, we want to do damage control, then resection of the perforated area, diversion proximally with a spit fistula, feeding tube distally, and come back at a later date for our reconstruction to reduce your mortality. And that's pretty much it. So what I'll do is go through a few questions about some clinical scenarios and try to answer any questions. So this is let's go through. This is a question here. Following a large meal, a man vomits several times and develops severe upper abdominal pain radiating through his back. Chest X-ray shows blunting of the left costophrenic angle. So what is the next step in management? So this tells you several times vomiting, upper abdominal pain, chest X-ray shows some fluid in the left chest. So this could be consistent with perforation. So would you obtain a serum amylase concentration? So probably not. Aortography, so are they trying to tell you aortic dissection or something? So we know with the vomiting and so on, we don't want to do that. Immediate exploratory laparotomy, not necessary because we don't know where the site of perforation is. If it's in the chest, laparotomy wouldn't help you. Gastrographin study, certainly want to do some kind of contrast study to look for evidence of extravasation and treat accordingly. So D is the answer. NG tube placement and antibiotics. So certainly antibiotics, but we should not put an NG tube in patients who have suspected perforation because you could make the defect larger. You could make a partial tear into a full tear. You could make a Mallory-Weiss tear to a full thickness tear. So you don't want to put an NG tube blindly. This question, a 40-year-old male presents with dysphagia, regurgitation of foul-smelling food matter consisting of food eaten 1 to 2 days prior. Esophagram shows moderate size outpouching in the posterior wall of the esophagus C5 to C6, and the pouch opacifies with contrast. So this tells us, could it be a Zenker's diverticulum? So the most common location is between the inferior constrictor and the cricopharyngeus muscle. So that is the potential weak spot of Killian's dehiscence. So this is probably the right answer, where the patient has a false diverticulum in the left neck with an air fluid level through the potential weak spot. Very few patients with Zenker's have associated hiatal hernia. So this is false because most patients with diverticular cricopharyngeal hypertrophy hiatal hernia have some kind of esophageal dysmotility. So they all go hand in hand. It's a traction type of outpouching, so no, this is a pulsion type because this is due to the high pressure of the cricopharyngeus muscle. There's outpouching of the esophageal mucosa due to pulsion. Durable repair can be achieved with diverticulectomy alone. So no, you don't have to do diverticulectomy, but you must do a cricopharyngeal myotomy. You must do the myotomy. It's a true diverticulum, so no, it's a false diverticulum because it's not full thickness. So this is a spot diagnosis here. The most common benign tumor of the esophagus is and we know the answer from our initial discussion. It's a leiomyoma. All these others may occur. These are usually asymptomatic, but this is the answer for this question. I think that ends our discussion. And thank you very much.